So I'm going to talk about failure of PTFE grafts in the lower extremity. That looks good. And how to manage them in the current situation. And Neil Kane, who's trained me, I guess, as a fellow, is an important participant in this. And what we're going to talk about is an improved hybrid method to salvage failed PTFE grafts when endovascular treatments fail. I mean, lysis and clot removal is one way of doing it, but sometimes it doesn't work. And the reason it doesn't work is there fibrinous or fibrinoid plugs, which are more than clot, which form at the distal or proximal end of PTFE grafts and are associated with failure. And lysis and aspiration just doesn't get these out. So some history in the 60s and early 70s, the standard treatment for critical limb ischemia, people forget this, was amputation. And our group was one of the first to advocate a very aggressive effort at limb salvage for critical ischemia. Now it's very popular because the cardiologists are trying to take it over. And they don't remember our papers going back all the way to 1976 or 78. And we showed then, in subsequent papers in 81 and 90, that almost all, somewhere between 95 and 99% of threatened legs had arteries that were suitable for either a PTA or a bypass, and that's because we had really superb angiography. Nobody else had it in those days, and it showed the little vessels below the knee and below the middle of the leg into the foot, and nobody was even visualizing those in the beginning. So we were able to treat these patients and save the legs when nobody else could. And we were also, which relates to this talk, the first to stress the importance of reoperation or reintervention when a primary bypass or PTA failed. Interestingly, our group was also one of the first to combine open surgery with PTA when surgeons thought that PTA was just ridiculous. It was like being a snorkeler. If you were a surgeon that advocated PTA, but we were, and we worked with our radiologists very well in that regard. And then when stents came along, we started to use them too. So anyhow, more about reoperation. The old technique, and as I say, we were very aggressive about re-intervening when a primary procedure failed and the limb was re-threatened. Sometimes the limb wouldn't be re-threatened, but most of the time it was. And I was once asked at the American Surgical, when is enough enough? And I basically said, enough is never enough. If the patient's leg is re-threatened, do something else. And we had two approaches. One was to do with a failed bypass, PTFE, which people still don't believe in, but they do work. We did a totally new bypass to a virginal vessel. Or, if one wasn't available, we did a thrombectomy of the graft with salvage or all or part of the old graft. This required a redissection of the distal anastomosis or the proximal anastomosis if it was involved, and the adjacent arteries, so you could get control and wouldn't have your field obscured by bleeding. And it was difficult, and it risked infection because the one thing that promoted infection in our many, many bypasses was reoperating on a previously dissected artery. There was about a 5% infection rate, whereas other things didn't correlate with infection. But it was necessary because you had to remove that fibrinoid plug from the anastomosis and the adjacent artery. And there's no way that lysis or clot aspiration would do that. So you had to see in the lumen to get that plug out and to make the diagnosis of the cause, because you couldn't see why the graft had failed, because you couldn't do an angiogram because the graft in the adjacent artery was thrombosed. So you had to open the artery, look in, open the graft, look into the anastomosis, pull out the plug, and see what else was causing the failure. And this shows how it was done, you can see this is the distal anastomosis, the difficult dissection of vessel loops around the proximal and distal artery. This was not easy because it was so scarred from the previous surgery. And then you looked in, did a thrombectomy with a Fogarty catheter, looked in, removed the plug, and if there was a distal stenosis that caused the failure, either intimal hyperplasia or arteriosclerosis, you put a patch on, or you did an extension if it was extensive distal arteriosclerosis. And these operations, though they were difficult, they worked. But then in 1992, as we learned from our EVAR experience and endovascular graft experience, we had an epiphany, and we realized that using the digital fluoroscope and catheter guide wire techniques could be used in the operating room for these failed grafts, as well as for putting in endografts and other endovascular grafts. And the new technique, which evolved in 1993 and avoided some of the difficult parts of our old technique, was to use fluoroscopy and endovascular adjuncts to simplify and improve the treatment of these failed PTFE bypasses. And this approach involved approaching the graft not at the arterial dissection site, but anywhere in the middle where it was often sub-Q and very easily accessible. So you didn't have the problem with these hard redissections. And then we did a thrombectomy with a balloon catheter of the loose clot and so forth, or we used, and this, it's in yellow on this slide, an inherent clot removal catheter designed by Tom Fogarty, and under fluoro control, that device, and I'll show you pictures of it, was able to remove the fibrinoid plaque and fibrinoid thing that was occluding the graft, or adjacent to the occluded graft, and then allowed you to get visualization so you could use endovascular techniques to treat whatever the problem was that caused the failure. And that involved doing a PTA, an angioplasty, or putting in a stent, or extending the procedure as needed, all under control of the fluoroscope. And so here's how it's done. I'm sorry, maybe I have a pointer, right? I can't figure out how to use this pointer. So anyhow, I'll describe it. I don't think it's going to project on the screen. Oh, great. Well, anyhow, here's the PTFE graft, dissected free, sub-Q in the middle of the thigh, the anastomosis in the popliteal and the femoral somewhere. And then we made an opening in the graft, an incision in the graft. Obviously, there's no bleeding because it's occluded. And we put in a Fogarty catheter and got out the loose clot. And you can see here the graft is thrombectomized, but you don't see any outflow tract because it's occluded and there's a fibrinoid plug in it. And I guess this shows the passage of a Fogarty catheter. It doesn't show it very well from where I'm at, but you can see that there's a distal plaque in that artery, and it deforms the Fogarty balloon, or the balloon catheter, so you can actually see what's going on. And then after the clot is removed, you get either prograde or antigrade bleeding, and from the graft, because you've removed some of the obstructing clot, you haven't really fixed the problem. So we put in a large sheath and then control it with the vessel loops here, so you wouldn't have bleeding. And everything was then done through the sheath and passing a guide wire through the distal anastomosis. And again, I'm having trouble seeing it from my vantage point here, but the adherent clot removing catheter has two beads, one here and one here. And fluoroscopically, you can see these beads, and when the two beads are apart, the blades or wires that are on the adherent clot removing cath are not deployed. They're parallel to the shaft of the device and not deployed. And I'm having trouble seeing this from where I am, but as you bring the beads together, the wires, and I'll show this in the next slide, the wires are deployed and can engage the fibrinoid clot, or fibrinoid thing that's including the clot. I can't see it because of the angle here. Can't see it either side, but I'll show you what is done. And then working inside the vessel, here's the handle of the adherent clot remover. And again, I can't see the beads the way I should, but when they're apart, the wires are not deployed. And as you move the handle move the device, the button on the handle, the beads come together and the wires are deployed. And this shows the wires deployed and this fibrinoid material that's caught up in the deployed wires. So you can get it out of the graft. Obviously, you don't want to deploy this in the artery because you'll tear up the inside of the artery. So you have to control the location of this fluoroscopically. And then after that fibrinoid material is removed, we did an angiogram. Remember, we've got a guide wire through. There's a stenosis here in the outflow vessel. And by using a balloon catheter, we're able to dilate that stenosis and restore good flow to the graft and to the outflow tract and rescue this situation. I'm sorry, one of the slides of the adherent clot remover didn't show, so let me go back and see if I can show you that, because that's pretty important. Can you go back? Can you go back on the slides? You have to keep going quickly back, because either I skipped it. No, this is, stop there. Yeah, but my reverse button ain't working. Anyhow, this is the handle of the adherent clot remover. And now let's go back again, because I have a picture of the device. Keep going back. No, somehow it's not here. Okay, never mind. Somehow it's not coming up. But it basically is a catheter passed through the sheath, not over a wire, and it has wires that are parallel to the shaft, and when you move the button on the handle, the wires are deployed so they actually are inside the wall of the graft, and you can see that they're deployed and you can see the location fluoroscopically. I'm sorry, for some reason the slide that shows the device didn't show. But anyhow, the conclusion is that using this new hybrid technique provides a simple and safe and very effective way for restoring graft patency with and still minimizing the potential for infection, damage to the adjacent artery, and the need for anesthesia. And the interesting thing is, when many surgeons did thrombectomies of these PTFE grafts, they didn't get that fibrin plug out. They get some blood back because of blind passage of a Fogarty catheter, but that fibrinoid plaque or substance was still occluding the distal end of the graft. And obviously, they'd restore proximal flow, they'd get good retrograde flow, and immediately it would fail again. So how you do something is important, and this is an important adjunct for rescuing these grafts. Anyhow, thanks for your attention, and I'm sorry that didn't show up better. Maybe I can get the slide later and show it to you.